Hi, everybody. This is Dr. Daniel. Today I'll be talking about treatment of menstrual migraine. Migraine has an incidence of 12% and is present in 25% of women and 6% of men. For women, migraine is their most frequent medical problem of all problems. The cause of migraine is not completely understood, but menstrual migraine relates to the fall of estrogen during a woman's monthly cycle. For most women with migraine, their monthly menstrual migraine headache is the worst, the longest, and the most difficult migraine they get, so that good treatment for menstrual migraine is really important. Treatment of menstrual migraine is adhering to a migraine lifestyle and treating early with an NSAID such as naproxen or ibuprofen twice a day for 5 to 7 days. Early, using a short-acting triptan such as sumatriptan, rizatriptan, or elatriptan. And migraine patients with more frequent headaches should consider using a preventive medication. Related questions. How is menstrual migraine defined? Menstrual-related migraine with or without aura is defined by the International Classification of Headache Disorders, ICHD-3, as migraine with or without aura that occurs 2 days before or 3 days after the onset of menstrual bleeding, where menstrual onset was defined as day 1. Menstrual migraine is also called catamenial migraine and is further divided into pure menstrual migraine, where migraine headaches only occur during the menstrual cycle, which is in about 7 to 14% of women, and menstrually related migraine with or without aura, where the headaches occur at menstruation and at other times during the month as well. This is the most common type of menstrual migraine, occurs about half or 50% of migraineurs. Does adherence to a migraine lifestyle treat menstrual migraine? In general, women with migraine are encouraged not to ignore their cycle, but instead plan for it. They're advised to relax their personal and work schedule during their cycle and to get lots of rest, exercise, and proper nutrition. This is important because menstrual migraines are more severe, last longer, and more difficult to treat than the usual migraine. The migraine lifestyle is adequate eating, proper amount of sleep, exercise, limiting or eliminating caffeine, dealing with stress, and avoiding overtreating with medication. Other ideas are avoiding stress and food triggers, and charting barometric pressure changes. What about keeping a diary or a chart of migraine and menstrual cycle occurrence? There are a number of free cell phone apps for keeping account of migraines. Charting the occurrence of migraine in the menstrual cycle for several months may help ensure an accurate diagnosis of menstrual-related migraine. Check out my blog article at www.drmigraine.com on list of helpful migraine cell phone apps. There's also a thing called the Menstrual Migraine Assessment Tool. It's MMAT. It's a simple questionnaire with 3 questions. It's shown to be fairly accurate at diagnosing menstrual migraine. The 3 questions are, do migraines occur in the space of time 2 days before the beginning of a woman's period until the 3rd day after the start of the period? And does this happen in most months? Do headaches that happen during this time become very severe? Does a woman experience photophobia, which is when a medical problem causes light to bother a person's eyes? The answer to the first question has to be yes, within the 2 to 3 days cycle thing there. And there has to be at least one answer to either question 2 or 3. Answer yes to either 2 or 3. When to treat migraine episodes. Treat several days before, during, and after a menstrual cycle if the migraine doesn't come consistently at the same time or if you have irregular periods. If the migraine usually comes the day before you bleed and you have regular periods, then start treating several days before bleeding. A variety of drugs may be tried, and the following list is from simple and cheap and few side effects to complicated, expensive, and possible side effects. Simple drugs to try for acute therapy. Try over-the-counters like Tylenol, acetaminophen, Advil, which is ibuprofen, or Aleve, which is naproxen taken as once or twice a day during the 5 to 7 days there. Naproxen is used more often and lasts longer. Cambia is also an NSAID approved for acute treatment of migraine. DHE, or dihydroergotamine, an injectable intramuscular DHE, or nasal spray Migranol may be tried. Triptans, oral triptans, and there are 7 of them. and I'm not going to list them all, but they're on articles about this in my webpage. Frova and Emerge are used for menstrual migraine due to their long half-life. Frova lasts 26 hours and Emerge lasts 6 hours, but both of them take 1 to 2 hours to work. The acute fast-acting triptans are sumatriptan, zomatriptan, rizatriptan, almotriptan, and elatriptan. Frova, because of its long 26-hour half-life, has become the drug with the most evidence as a short-term prophylactic agent for menstrual migraine. One Frova trial demonstrated that 57% of patients were migraine-free over the course of 3 menstrual cycles. The regimen used was 1 or 2 of the 2.5 milligrams of Frova triptan twice a day, starting 2 days before the onset of menstruation, for a total of 6 days of treatment. With this regimen, the patient can also take an additional 2.5 milligram dose once a day for breakthrough headaches. This treatment program is efficacious in women who have pure menstrual migraine and in select difficult-to-treat women with migraines where previous abortive treatments had failed. Because of this result, short-term prevention menstrual migraine with Frova has been given an A rating by the American Headache Society and the American Academy of Neurology for migraine prevention. There are new acute treatment drugs and devices for migraine 2020, and we don't know a lot about how these drugs are going to work because there's not much published nor patient use. But we've got Nurtec, Ubrevely, and Rayval. And along with that, you also got Cephally and Gammacore devices that can be tried. And they should be considered mainly for triptan failure patients. There's a concept called the mini prevention strategies. You can use NSAIDs for this, like NSAID taken twice a day during the 5 to 7 days surrounding the menstrual window may eliminate the menstrual migraine. Should a migraine occur during that time, it's likely to be less severe and becomes more amenable to treatment by triptan. Naproxen 550 milligrams dosed twice a day as a mini prevention was shown to be effective when studied, and the benefit is believed to be a class effect so that all the NSAIDs actually give similar results, but naproxen has a longer half-life. Triptans. Multiple studies have been done with acute medications typically used to treat usual migraines, but dosed continuously in the menstrual window twice a day. This approach appears to decrease or eliminate menstrual migraine, although there are concerns that the migraines be worse or become frequent at other times of the month, possibly related to rebound or medication overuse. This will particularly be problematic in women who have frequent migraines throughout the month as well as menstrual migraines. Except during the menstrual time of 5 to 7 days, everybody is supposed to limit triptans, NSAIDs, any other kind of migraine medicine to no more than 2 days a week. The American Headache Society evidence-based guidelines rated Frova as Class A and Naratriptan and Zomatriptan as probably effective, Class B, for use in many prevention. However, the FDA did not feel the evidence of benefits for Frova was sufficiently strong to approve it for this indication, as not given any triptan a recommended indication for many prevention. Triptan dosing for many prevention is generally given twice daily. Either niratriptan 1 milligram or zomatriptan 2.5 milligrams or Frova can be used here. NSAIDs, usually naproxen and a triptan taken together at the same time, or as one pill as Trexamet may be used, and probably more powerful than either naproxen or triptan alone. Preventive drugs for menstrual migraine. If the headaches are bad enough, some women should consider getting on a daily preventive drug. Any of the group of drugs that may be used for prevention may work. They may be taken every day during the menstrual cycle, every day of the month. Data concerning the use of long-term preventive agents for menstrual migraine is sparse, and the use of standard migraine preventive drugs is currently the most common form of therapy. And these drugs include propranolol, atenolol, topiramate, Trokendi XR, or Qdexy XR, and Elavil, which is amitriptyline. Depakote should not be used as it is completely contraindicated in menstruating females and has an X-rated warning from the FDA regarding teratogenic damage to the fetus. But the new CGRP drugs, Aimovig, Yapeti, Emgality, and Ajovy, are powerful new drugs for migraine prevention that are given parenterally every month or 3 months for migraine prevention. Estrogen. Many doctors prescribe estrogen-based birth control pills, estrogen IUDs, estrogen patches and pellets, and injections to persons with migraine. Estrogen drugs are all contraindicated for migraine by the FDA, can make the experience of migraine worse. They're all relatively contraindicated by the FDA for patients with menstrually related migraine and migraine without aura, but they're absolutely contraindicated for women with migraine with aura because of the risk of stroke. Migraine with aura alone carries a 6% stroke risk. Other problems are that estrogen treatment is called a class 1 carcinogen, that is, a drug that may cause cancer. The incidence of breast cancer in 1960, before the pill came out, was 6%, but nowadays it's up to 8%. Also, these estrogen treatments can cause abortion by making cervical mucus thick so that an embryo can't move down the tube and implant in the uterus. And IUDs work by scraping an implanted embryo off the uterine wall like a lawnmower cuts grass. At this time, additional data are needed to make specific recommendations regarding long-term prevention and therapy of menstrual migraine. Warning regarding treatment of menstrual migraine with estrogen drugs. Elizabeth Loader published a book on menstrual migraine as a professor of neurology at Harvard in Boston. She was chosen by the American Academy of Neurology to lead a team of neurologists investigating hormonal treatment of migraine with menses. These doctors reviewed the literature and then published the following article in the journal Headache. Hormonal management of migraine associated with menses and the menopause, a clinical review, Headache, published 2007. And their summary statement is that, quote, hormonal treatment of migraine is not a first-line treatment strategy for most women with migraine. Evidence is lacking regarding its long-term harms, and migraine is a contraindication to the use of exogenous estrogen in all women with aura in those aged 35 or older. The harm-to-benefit balances of several traditional non-hormonal therapies are better established. And with that statement, I am really through with my thoughts here on the treatment of menstrual migraine headache. Please click on like. Thanks for listening to this. Click on subscribe so we can follow each other. God bless all you persons who have migraine, particularly women with menstrual migraine, and the difficulty of treating that. And I will see you on the next talk.